I think to start with, right, there's this sort of, want to remind you why we're here. So how many of you already know what claims data is, generally speaking? Great, because we made this super introductory, so excellent news. We're going to tell you. So to cut to the chase, and we're going to obviously talk a lot about this over the next hour, what is claims data? So generally speaking, claims data represents information from healthcare encounters that can help us learn more about how the healthcare system works. So essentially what we're talking about is the result of the billing and payment of medical services. So anytime you go to the doctor, you go to the hospital, someone pays for that. Now if it's you and you pay out of pocket, you give them $20 and they never call you again, we don't have that data usually, right? What we're talking about is that the majority of healthcare services in this country get paid for by some kind of payer, right? So an insurance company or a government payer like the Veterans Administration or Medicare and Medicaid. And so that's sort of what we're talking about here. So claims data includes information on what services were provided. So it includes these sort of types of things. What was the service or the drug that was provided, and when was it provided? What was the diagnosis? What was wrong with the person that led them to provide that service? Where did it happen? So was it at a hospital? Was it in a physician's office? Who was the person that provided that service? And how much was paid for the service? And we're going to get into this. There's a lot more detail about sort of all of these things, but this is sort of the high level. This is what you would expect to see in claims data. So what's important here is that it actually does not include things like you would find in a medical record, right? So you know someone got a blood test, but you don't know what happened. You don't know what the result of the blood test was. So part of this is sort of thinking about what you can infer from that level of information. So we'll sort of talk a lot today about what claims data actually includes, what the information is, because that'll lead us through this seminar series to some of these questions about, you know, what kind of things you can actually do with claims data given what's in it and what the limitations might be. So we're going to cover sort of some of those ways that we can harness this as well as certain weaknesses. Mm-hmm.
Is this anonymized or is it linked to because the data?
Well, so in theory, so we're not going to show you anything today that is sensitive information. In general, right, the payer would be maintaining beneficiary identifiable information. So whoever has your insurance right now in their claims data stores, or any insurance you've ever had probably since computers were invented. So for most of you, that would be any insurance you've ever had. And me. Just, but I think that they'll maintain that in an identifiable way. And depending on what kind of work you're doing, you might have those identifiers or you might not, right? It really depends. So the payer has them. But depending on what your research purpose is, what you said, HIPAA is a set of laws, really, that requires that healthcare providers and payers protect your personal information. And so they're not allowed to give that personal information to people except for a certain set of sort of codified reasons. You can look up, it's like in statute, right? This is what HIPAA says you can and can't do with healthcare data. And so that's an important aspect of thinking about what would be available in any given scenario.
By and large, if you're doing research, it's de-identified. But if you're working in a hospital setting and you're producing an algorithm that's going to help clinicians to identify patients at risk, then obviously the physician needs to know what patient. Well, then you're going to identify it.
So the next slide is just introducing us, which you already did, right? Which is great. I think that we're both probably going to draw, you know, on this as we do in our jobs from some of the things we did before we had these jobs. So both T and I have been with Milliman for I've been there for 3 years.
Yeah, we could round to 3.
Yeah. And we both actually formerly worked for a government payer, right? So I worked for the Centers for Medicare and Medicaid Services in their headquarters in Baltimore. And Tia can introduce herself. We're going to switch now, so I think you have to sit over here.
I worked for the Illinois State Medicaid Plan, and my role there was known in the colloquial as the queen of the data.
We don't have to move? Are they holding us?
Because on the...
I'll do whatever you want. I'll stay here for now.
So we have what's known in healthcare as the commercial, the Medicare, and the Medicaid perspective, because most people are covered, the vast majority of people are covered under one of the three. And then there's some other smaller programs such as a VA and such. So, I'm going to brag a bit about Milliman. First of all, I thought about what makes us special and how we fit into public health. And we do a lot of work that relates to public health. The difference that in our work, or sometimes what the difference is that we're much more focused on dollars. We deal with healthcare issues that have dollar signs attached. And we're the health practice of Milliman. Milliman also has a life practice, an employee benefits practice, and retirement, etc. All those things have dollars. We're big. There are a lot of us, 3,500 people, 3,400 people plus and growing around the world, $1 billion of revenue. And we love data and we hoard it. Yes. But not only do we hoard it, we use it. And in the process of using it, we have figured out how to make sense of it. So over the years, decades, we have built data tools. And then when we get something that's really good in-house, we sell it out, we sell to other people. So our tools, the very tools that we use on a daily basis in-house, have become gold standards for the industry. As I said, the health practice is one of several practices in Milliman, but we're the biggest. And we personally think we're the best. We're multidisciplinary. Milliman started out as an actuarial consulting firm. There are, warning, a lot of actuaries hanging around. But we have clinicians, data scientists, MPHs, MBAs, PhDs, and one DRPH, that would be me. And many people are multi-credentialed, so, MDs with MBAs and data scientists with MPHs, etc. Our office alone has more than 200 peer-reviewed journal articles, published white papers, issued briefs, etc. And we are located essentially above Penn Station, just one building next to Penn Station. Of course, Madison Square Garden is right above, but right next door. And that's our building. And we've got a killer view, 38th floor, unobstructed. So I only joined Milliman for the view. Because we're big and because we really, really know healthcare data, or at least the healthcare data that has the dollar signs attached to it, we've conquered it. Anyone who wants to know about what healthcare costs, sooner or later shows up at Milliman's doorsteps. And it makes generating new business challenging because everywhere you go, there's already a Milliman consultant who's worked for them. So, but that's my problem. We use a lot of different data, but the common element in most projects is it's some aspect of the project references claims data, because we are exceptionally strong at developing claims data. This lab, we've covered a little bit of it. We're starting this fall with a soft start. We're going to have 3 introductory sessions because you all need to decide whether this is for you or not. And we noticed that we realized that not everyone even knows what a claim is. So it's hard to commit to a claims lab if you don't know what a claim is. So that's why we're here. Soft start, get to know something about claims data. The actual lab, the hands-on lab, let's play with data, let's figure out what the challenges are, let's support each other in the learning process. Starts in the spring, at which point we'll meet every 2 weeks to give mini lectures, and we'll bring in staff members, young staff members who are actually writing code to help to both help give mini lectures, but also to help answer questions. And then the goal is that ultimately this will support your practicums and your career plans. When you could say, all right, we get resumes and we're like, you know anything about claims data? Diagnosis codes? Procedure codes? SAS? SQL? And if the answer is yes, they get an interview. The answer is no. Next basket. So I think this is an important point. We are topic agnostic. There are other labs at the school that are, study cancer or nutrition, etc. I know those are fine things and they're fun things, and maybe you should do them. But we're not topic area. We are technical skill, and you bring your own topic. So if you want to study cancer or obesity using claims data, obesity is a tough one because we can talk about it doesn't actually show up well in claims data. But if you want to study diabetes, then come here. And we will be hands-on. So this week's session. The next one is in a month, assessing and leveraging claims data. So we'll talk more about the data. And then the third one will be a brainstorming. What might you be able to do? Maybe you've come up with some thoughts during the first and second session. It takes some technical skills. If you're just an Excel user and we get to the hands-on, anyone's welcome to come to the sessions, but when we get to the hands-on part, if you're just an Excel user, you're going to struggle. The data sets that we have a very rich learning data set that we're going to use for the spring. It's in SAS. Now you can get it out of SAS and put it in something else, but you have to figure out how to do that. And that's part of the joy of being a data person. Or you can keep it in SAS, because SAS is a wonderful tool, and SAS is a tool that we use for a lot of our analyses. Given the size of the data, you can probably manage to do it in Access if you insist. I'd rather you didn't, because it's really to your benefit if you can conquer one or more of these other software tools. This is where you can lean on each other, of course. See that splashing up there? No Excel. But you can do these. Okay. Pamela.
Here, why don't you just shoot me the mouse? You can split it. So we're back to this question, sort of what are healthcare claims, right? So like we said, the way that a healthcare claim is generated is that a provider renders some kind of healthcare service, right? And then they submit a claim to an insurer. So like I said, sort of the only scenario in which this doesn't happen is really patients who are paying out of pocket or not paying at all, which is a minority of healthcare interactions at this point. But that probably wouldn't show up in a claims database that we have, right? So then the claim gets processed and paid, or it gets denied by the insurer, right? But the insurer does something with it. So they either pay the provider, they tell them why they're not going to pay. And that whole process is well documented, and lots of different data elements are saved, right, by the insurer. And so that's what we talk about when we're saying healthcare claims data. So, for you personally, right, your healthcare claims data is being held by every insurance company that sort of you've ever touched, right? And it represents this record of all the services that you've ever received. And so getting into a little more depth on what we talked about just, at the beginning, these are the types of information that you would expect to see on these claims. So first, there's going to be information about the person. So what their name is, where they live, demographic information. So usually we do see, we see age, we see date of birth. Depending on the payer, we sometimes see date of death, sometimes we don't. Things like their gender are on there. Some race is sometimes on there. There are demographic variables. Then there's eligibility information. And so for a lot of insurers, there are different ways you can be covered, right? And so we're not going to probably get into a lot of detail about that today, but you might be in a comprehensive plan, you might be in a high deductible plan. What kind of coverage do you have? What does it cover? So the example, we're going to use examples, I'm going to use examples from Medicare a lot, both because that's what I know, but also because that's sort of the most readily available source of claims data, which we have to share with you or that you can get access to. So in Medicare, there's hospital coverage and there's what they call supplementary medical insurance, or Part B coverage. And so Part A, or hospital coverage, is something that everyone just sort of has in the US if they've paid their taxes for long enough and they've reached a certain age. Hospital coverage just comes, right? Supplementary medical coverage, or Part B, you have to pay for. So people will elect into it or they'll elect out of it. So that would be sort of a piece of coverage information. So you might say, oh, today I don't see any provider claims for that patient. You know, there aren't any after June. Well, is it because the person didn't actually have coverage? And so if they were getting physician services, they wouldn't show up in a medical claim. It's important to know that eligibility information so that you know if a lack of claims actually means that the person didn't have any healthcare services, or it means that they didn't have any coverage, and so that insurer wasn't paying for them at the time. The next category is provider information. So we'll see some kind of identifier as to who rendered that service, specifically what doctor. And in the Medicare claims, we have actually the name of the doctor, and this is something that Medicare has been doing a lot of, and you've probably seen it like in the New York Times, right? They've released information about what types of services different providers have rendered and how much they've been paid for them. So you can actually go, I think on the New York Times website, they have like a little tool. You can type in the name of any doctor you've ever seen, and it'll say how much money Medicare paid them last year and for what services, like what did they do, right? And it can be kind of interesting. I mean, it led to a lot of churning in a lot of circles about how much gets paid for certain services. You know, sort of surprisingly to many people, the highest paid I think were like eye doctors, because they prescribe some extremely high cost drugs to treat various eye conditions. And so that was something that I think a lot of people didn't expect, that sort of came out of Medicare just releasing a lot of claims data. So the next category is service level information. So this is like a big category, right? So the idea that it actually, the claim needs to say, what happened in this interaction? So there's some reason, the diagnosis, why the patient came to the hospital or to the doctor. So that would be something like they have diabetes, right? Or they have cancer. It would be a condition. And then there's the procedure or the service. So what did the doctor do? So that would be, gave them a vaccine or gave, prescribed a drug, sort of did a procedure. I did a knee replacement on this person. So the combinations of diagnoses and procedures, each of those has completely sort of separate coding systems. There are lots of different medical coding systems that are used here. So for diagnoses, we usually see something called ICD-10 code. So it used to be ICD-9 and they just changed it. This was another sort of hot topic, right? Was the doctor, no one wanted to use this new system, ICD-10. As a fun side note, I think that ICD, they're actually on like 11 or 12 now. Like we're
the rest of the world.
The rest of the world is using, and it took us how many extra years?
Well, and our 10 is the rest of the world's 10.
Right, so the ICD-10 system is a much more comprehensive system of codes, right? It has very many more codes to describe different things. So I hear some people laughing, like this is something that was also, you can look up some of the codes for like things. There is now actually a code that says like, I got hit by like a turkey crossing the road for the second time, right? Like it creates this like crazy array of different things.
There's one about getting sucked into a jet engine twice.
Right. And so the thing is, like, we can pull out these things, they are really interesting, but the reality is, like, the system is set up so that there is just, whereas before there was less intelligence in the number, right? It used to just be like, there's a 5-digit number, essentially. Now there's intelligence in every digit that creates a system where, like, you can say it happened the second time or the third time. That's just built into the system. But yeah,
some of that's fraud prevention. You shouldn't have your left leg amputated twice. And in the old system, there was no differentiation between left leg and right leg. And there's a bit of a misnomer when we talk about diagnosis codes and procedure codes, which come irrelevant to what I'm about to present next. The need for a screening test is a diagnosis code, even though there's actually no diagnosis with a screening test. But because we need to fit it into the taxonomy of how health claims are coded. There's actually something called a V code, screen test or V code, yes. Well, that's under ICD-9. I forget, I don't even know what it is in ICD-10. Okay. Procedure codes are usually a service that's provided, but it can be a thing. It can be a wheelchair. It can be a diaper.
Yes. And so I think one thing that I want to make sure to drive home sort of while we're talking about this point is that, you know, I have this slide. I think this is the only slide we have that says like what's in claims. Now this like looks simple. You're like, why can't I have that in Excel, right? You have a row. It says this person went to a hospital and they got this thing for this, right? And the reality is each of these things has a lot of levels of complexity, right? So let's say you go to a physician office and you're going for like a regular checkup, right? So they're gonna say, you know, the procedure I did was a regular office visit. That's a code, right? And just regular evaluation and management of this patient who I've seen before. But then they might do other things, right? And so each claim might have a whole bunch of lines on it that say, I went to this doctor one time. So there's only one date, there's only one doctor, right, in theory. But then I put on 18 different things I did. And each of them might have a different diagnosis that it wants to point to say, I did this thing because of this reason, I did this thing because of this reason. And so typically, when you think of an insurance company that's having millions and millions of these interactions coming in, you know, every day, they're going to store that data in the way that's the smallest, right? And so the way that's the smallest is what we would call a relational database. And so that's the issue where we get into saying, you know, you sort of really need to use one of these ways to look at claims that allows you to link that data together in sort of logical ways because of the way it needs to be stored and handled. In theory, right, you could make one row for like every iteration of these things, but that data set would be enormous, right? You wouldn't be able to open it in Excel anyways. So on the right, we get into this billing and payment information. So now we know sort of what happened to the patient, where they were, but then who paid for that, right? So someone has submitted this claim to the insurer. That's why we have it in our claims database. Was it approved or denied? Sometimes the insurer will say that's not covered under your plan, so we're not going to pay it, right? Was the provider paid some amount? So they will typically put on the claim a billing amount or a charge amount. They'll say this is how much it costs me to provide this service. Those amounts are usually fake, right? Like they have a schedule where we always say this is how much it costs for this thing. That's a big issue in healthcare generally about sort of this idea that people don't actually know how much it costs to provide these services. But they will put a charge amount. So they'll sort of add up all the things they did or the units of time, whatever system they use, and say, this is what, you know, we are charging the insurer. And that usually has only a medium amount of relation to how much they get paid for the service. Because usually the insurer will have a fee schedule of some kind whereby they say, for this thing we pay this much, or we have a negotiated rate with you, so we pay a little bit more, a little bit less. But those are very much separate things, right? So there's an amount the provider bills for the service. They say this is how much we want to get paid. There's an amount the payer says, we have a rate schedule, and this is what we would call like the allowed amount. So this is the amount we allow to be paid for that service under this person's coverage. And then there's the amount they actually pay, which still might not be the same amount, because in many cases the patient will have some liability for that. So they'll have to pay a deductible or co-insurance. So the allowed amount is really like the insurance company saying, you know, we allow $10,000 of coverage for that service. The beneficiary has a $1,000 deductible, so they have to pay the first $1,000, and we'll pay you $9,000. So then they go back to, they tell the provider that in what's usually called like a remittance advice. So they write back to the provider for this claim, and they say, here's your $9,000. That person owes you $1,000. You can go get it, right? So we'll see that. So we'll see the amount the beneficiary is liable for. You typically wouldn't see if they paid, right? But you'll know if the beneficiary was supposed to pay, right? Because the insurance company doesn't actually know if the beneficiary paid the hospital the $1,000 or not. So we can't see that in the claim. And then there's also this third-party liability issue. So sometimes people will have more than one insurance. And depending on the insurer, they might keep track of that. So particularly with Medicare, oftentimes people will have secondary coverage. So they'll have like a Medigap plan, so a different plan that they pay for that covers their liability amounts, their deductibles and coinsurance. And Medicare actually has a system that keeps track of that, and so they can actually send those bills automatically, which is a nice system for Medicare beneficiaries that sort of, when Medicare gets your claim, they say, okay, we owe $9,000, the beneficiary is $1,000, but they belong to this private plan, so we'll send that $1,000 bill to the private plan and see if they pay it first. And so sometimes insurers will do that and you'll have additional information. But there really is a lot of information about how much was sort of paid. And I think that leads to an interesting point, which we'll get into in a lot of ways in this lab, about how people pay for things, right? Because sometimes there is just a fee schedule, and sort of you say, oh, the patient went to the hospital, they had this service, it pays at $12, right? Here's your $12. Sometimes there'll be a bundle or a global amount. So for instance, a lot of surgeons, when they do surgery, there'll be a set amount that they get paid for the surgery, but also the follow-up visits that need to happen for 30 days. And so you might see claims where it says, you know, the surgeon billed for a surgery, the surgeon got paid $2,000. And then 5 days later, the surgeon billed for a follow-up visit, the surgeon got paid $0, because it's bouncing back in the claim system off of that, you know, we already paid you a global payment for 30 days, so we're not gonna pay you again in 30 days.
Is that the capacitance thing?
I'm sorry?
Capacitance or capacitation thing?
Oh, capitation. Yeah,
It could be capitation.
it could be. Do you wanna explain that? That's an actuary thing.
Yes, I mean, sometimes it's usually in primary care, the primary care physician will get a fixed amount a month per patient. And we refer to that in actuarial speak, per person, per month, PMPM. We love the term PMPM. And so say $40 per month per person, and then anytime the patient calls up and wants to see a doctor, the physician's supposed to see the patient. And the physician will still send in the claim, but it'll be classified by what's called an encounter claim. It'll look just like a claim. It will get processed through, it will have an allowed amount, but then the actual payment amount will be zero, because the health insurance company wants to keep track of what services were provided to what patient, but they're not actually paying for it because it's covered under the capitation.
And this is, I mean, this just brings us back to like another reason why I think it's useful to learn about claims data in the context of a data set like the Medicare data, because Medicare coverage policies are known and public. So you can look up, if you see something in the claims, like, oh, I'm seeing all these claims for this service and they're not getting paid, I wonder why that is. Like, you can go on the Medicare website and it will tell you what Medicare pays for and why, and what are the situations which they don't pay for that. And if you are working with like a commercial insurer, some private plan gives you their data, which happens for us with some frequency, right? Mm-hmm. We don't always know their coverage, and they don't always have it written down in a useful way, even internally, or that they'd be willing to give us. And so we have to sort of figure these things out based on what we're seeing in the data, which can be much more challenging. So we're gonna go into a couple examples here of like what you can and can't do with claims data based on what we've just talked about. So this is one example. So this idea, you know, if you wanna understand diseases in populations, right? So here's a question, sort of what proportion of the population, just generally, is being treated for cancer at any given time, right? So we had a client once that we did this sort of on their behalf, asked us essentially, can we figure out like how prevalent is cancer treatment, right? Not how prevalent is like, not incidence, right? And we don't necessarily want to know how many people have cancer. We want to know how many people have cancer that's being treated at any given time in any way. And so we created a claims algorithm where we said, here are sort of the procedures that we would count as treatment for cancer. So chemotherapies, radiation oncology, you know, surgery if it had a primary diagnosis code of cancer. And we looked through the Medicare claims and found sort of what percentage of the Medicare population has cancer that's being actively treated. So that's sort of the blue part is basically saying, you know, the entire bar is everyone who has cancer. So they have, you know, enough diagnosis codes on their claims that we can say that it looks like they have cancer based on the number of claims within the year that have included a cancer-related diagnosis code. And the blue section is how many are not being actively treated versus those who are being actively treated. And so what you can see here, this is over time from 2004 to 2014, there has been an increase in the percentage of patients people in the population who have cancer, but the amount that are being actively treated for cancer at any given time has gone up less, right? So if you look at the top in the Medicare population, the percentage of that population that's actively being treated for cancer, which is the green, has hovered below 3% for that entire time period. But the amount of people who actually have cancer that's not being treated has increased. So typically those are people who were like cured, right? Or they're in remission and they don't require active treatment. You can't necessarily infer that, right? That's an inference that we're making based on what we're seeing. All we know from this graph is the percentage of people who have a cancer diagnosis is going up, and the percentage of people who are being treated for it is lower. And the bottom is just a commercial population, so really what you're seeing is far fewer people in that population. Commercially insured is what that means. So typically that would be younger people who have employer-focused insurance or something like that. Their percentages are much lower in terms of who has cancer because it is.
Cancer is age-related.
So the next graph, on the same tack is sort of this question of, okay, we know who's being treated for cancer. How much more expensive are those people compared to people who don't have cancer? And so we sort of did the same type of analysis every year, looking at each of those populations. So the light green line is, again, people who are actively being treated for cancer. The dark blue is people who are non-active cancer, which means that they have cancer but they're not being actively treated. So it's the same colors you saw on the former graph. And then we have sort of the overall population as well as people who don't have cancer, right? So that's, just sort of to baseline that. And what you see here is sort of the increase over time in the active, the PPPY, the per person per year cost for those patients. So this graph doesn't show that, the finding, but the main finding here was actually that these lines are all increasing at approximately the same rate. So the fact is that, costs for everyone are going up. Obviously, it's more protracted because they started higher, right? So you have a 10% increase on $30,000. It's more than a 10% increase on $3,000, but the rate of increase of each of these lines is actually the same. And so then we say, where's that money going? So now we care about only those expensive patients, the actively treated cancer population. What are we spending that money on? So this is where we sort of went into the claims and actually divided all the claims into categories and said, what was this money spent on? So the section with the brackets around it, the blue, that's sort of chemotherapy, any kind of chemotherapy, whether, there are different ways chemotherapy works. But sort of what percentage of the spending goes into these various categories. So this is the kind of thing you can do in medical claims data, right? You can say, who has what diseases, how much did we spend on those diseases? But it's important to understand the shortcomings of the data when you do studies like this. And I think the next slide sort of illustrates that. So this is a study we show all the time, but since you don't know about claims data, you haven't seen it, and this is all very exciting. So diabetes, right? Is what was being studied in this study, right? So this chart that you're seeing in the middle. So someone was looking to identify patients with diabetes. So how often do you think it happens, just not in claims, just in life, that someone has diabetes this year, but next year they won't have it? I agree with you. So generally speaking, we would expect that patients who have diabetes in any given year will have it every year, right? It's sort of not regularly cured. And so what this person looked at was for 2 separate years. They took the whole population and they said, how many times did each patient have a claim for diabetes? So let's just focus on people who had 4 or more for a minute. So that's the first column of percentages. So people who had 4 or more claims for diabetes in a year, they probably have diabetes, right? If we look in the second year, how many claims did they have for diabetes? Almost 20% of them didn't have a single claim the whole year for diabetes in that second year. So why would that be? Maybe they didn't go to the doctor that year, right? It's possible. it seems more plausible that the doctors didn't code their diabetes diagnosis on their claims that year.
Or they went on to Medicare.
Or they went on to Medicare. Because there are different, just thinking about the way claims work, there are different factors that lead someone to put a code on a claim, right? And what we usually say is, if it doesn't affect the way you get paid, you're not gonna put it down, right? So if I get paid more because the patient has diabetes, I'm relatively likely to remember to put that code on the claim. But most people don't get paid more because patients have diabetes, right? It's a chronic condition. It is, obviously it's important and it's driving what kind of services they're getting, but physicians generally speaking, and again, coverage is different for different insurers, physicians generally speaking get paid for services. They don't get paid based on the diagnosis. And so diagnosis coding is notoriously incomplete for that reason, because we know that most independent, just physicians, aren't actually getting paid more based on that. There are some institutional settings, so hospitals for instance, the way they get paid, usually it sort of ratchets up if you have more complicated patients. And so they have more of an incentive to put those codes on the claims. But that's something you really need to understand. So that's sort of the first limitation we have is coding systems that are used to identify both diagnosis and procedures have system limitations. So sometimes we talked about this already. The codes might not be specific enough to identify something. So for example, prostate cancer is a condition that's of interest right now. Lots of men are being diagnosed with prostate cancer because of PSA testing, but not all of them necessarily need treatment. It would be neat, right, if the prostate cancer diagnosis codes had some nuance to them that said, this is an early stage prostate cancer patient, this is a metastatic prostate cancer patient, or this is sort of a mid-range, and there aren't, right? So there's only one diagnosis code for prostate cancer at all, right? And so there are limitations in the codes, and then there are also limitations of people actually putting the codes on the claims, putting them on at all, or putting on the right ones.
And to use that example, it doesn't mean all is lost. I actually use claims data to do a metastatic prostate cancer analysis. But we had to infer it based on the drug use, because there are certain drugs that are specific to metastatic prostate cancer.
So that goes exactly towards the point, right, that people get paid for services. Someone's getting paid for that drug, and so the drug had a claim, right? But it's, the other thing that we sort of already touched on is the availability of information on clinical factors, right? So the same issue there with maybe the person got a PSA test, but we don't know what the outcome was. We don't know what the result of that test was. We simply know that it was done. We don't know about cancer staging, pre-existing conditions. Most of the time we don't have information on. There is some limited coding that you can code pre-existing conditions, but a lot of people don't use it. And then there's, of course, no narrative information or clinical notes. So to sort of finish out this section and go into some examples, we've talked about the sources of healthcare claims. And so payers have this data on their populations, right? So we have the Centers for Medicare and Medicaid Services. They have Medicare data. So they have data on the aged population, people who are 65 and over, or people who have a disability that qualifies them for Medicare for whatever reason. That's going to be a different population. You're going to be able to study cancer really well, right? What are you not going to be able to study?
Pediatric illnesses.
Pediatric illnesses, right?
Medicaid is very heavy in pediatric, yes.
But the data isn't centralized for Medicaid. It's held by every state Medicaid plan, right? And they're all different.
They're all different, and there's been a huge effort of the federal government that by and large has failed to integrate this data across the board.
When I was at the Centers for Medicare and Medicaid Services, they were trying to run like a prenatal program. I remember in one of the requirements, they were going to practice and they said, you have to get your state Medicaid plan to agree to give us data on the patients who are in this program. And every single provider that had expressed interest came back and said, we could never do that. They will never agree to that. So there's private insurers, there's employers that self-fund their insurance for their employees, and so they typically will have or have access to the claims data for those employees. And then there's private companies. So, Truven, for instance, is a private company that aggregates claims data. They're getting worse at it over time. because you have to convince people to give you their data and then they're reselling it, right? And that's becoming harder and harder to convince companies to do. But there are aggregators. I mean, we do some of this as well. So for clients where we do actuarial work for them, if they give us their claims, we sometimes will say, we'll give you a discount if you let us use your data for research purposes. And so we are also building up our own sort of internal
Well, at this
claims.
point, we have as much data internally as we license from Truven, because Truven's data has decreased in recent years.
But they're the player. You'll often see it's called Truven Market Scan. You'll see it cited in papers. That's like the standard commercial claims database that brings together lots of different plans.
And not all is lost on Medicaid. I mean, the plans are, every state is different, but increasingly Medicaid is provided by private insurers. Medicaid agencies, state Medicaid agencies contract with private insurers, and you can get the data sometimes from the private insurers instead of Medicaid agencies themselves. And for certain public health projects in certain states, you can get it directly from Medicaid. In fact, I think NYU has a deal with New York Medicaid that gives access to some Medicaid data. But it does take, Medicaid data does tend to be a bit unique. That's an understatement. So we're going to give a couple of I anticipate we're going to have a rich discussion. So we're going to give a couple of examples, and I'm going to sail through them because I think I can tell you're loaded with questions. Or really want to hit the food, whatever. Okay, so remember public health with dollar signs. Cancer screening is a public health issue. So in colorectal cancer, there are actually multiple ways to screen for colorectal cancer. Until recently, was changing somewhat. The gold standard was colonoscopy, where you clear out the bowel and you put a scope up the colon and you take a look, and if you see anything at all, that's any bit of miss, you cut it out and you biopsy it. The alternative is you clear out the bowel, still not a pleasant process, and you put the patient through a 2-3 second CT scan. And you look at the CT scan, and if you don't see anything alarming, you send the patient home. And if you see something, though, then you send them to colonoscopy. So it becomes a 2-part test then. Colonoscopy, if the patient has a normal test, it's every 10 years. If abnormalities are found, it can be more often. Colonography, if a patient has a normal test at the moment, the recommendation is every 5 years, although some would argue it should be every 10 years. Colonoscopy is far more invasive, has more complications due to being invasive, more potential for diagnosis, overdiagnosis, because there are lots of very minor things that really don't need to be found. CT colonography, though, one could say there's a potential for underdiagnosis because there has to be a certain minimum size in order to find it on the CT. And the interesting thing about colonography is a CAT scan. So, okay, so now in the process of looking at the colon, you see the benign tumor on the kidneys, but how do you prove it's benign without some more testing, etc.? So those are referred to as extracolonic findings. So, rolling it all together, if you're Medicare, which do you prefer? And that's, that was a project I worked on.
It's like they push mammograms and ultrasounds before MRIs for breasts.
And it gets complicated, as we were talking about earlier, because there is no service called colonoscopy. I mean, there is a service called colonoscopy, but a colonoscopy is much more than the service called colonoscopy. Because even the service called colonoscopy has the physician component and it has the facility component, and they may be billed by different organizations. Or they may be billed by the same organization. And I have on the next slide, I'll show you, I have a list of what the components are. And the other thing is, at the time we did the study, colonography was not yet a recommended screening modality, so therefore Medicare actually hadn't set a screening price. And one would say, well, obviously, Tia, it's the same price as you pay for a abdominal CT. It's not, because Medicare can decide to pay something higher or lower for a screening abdominal CT than it does for a diagnostic screening abdominal CT. And the other thing is because it was rolling on and it wasn't yet a recommended modality. The concern was at the point it became recommended that there might have to be a shared decision making where the patient has to be counseled as to what modality and what the trade-offs are. And in fact, it's still not covered. It's still not covered under Medicare, but it is covered under the U.S. Preventive Services Task Force guidelines. So commercial carriers are covering it. So this is the list. This is the joy of our fragmented healthcare system. Because if you want to know what do these tests cost, then you got to figure in the cost of the bowel preparation regimen, the professional technical service, the anesthesia, which in there may or may not be anesthesia. It depends on the doctor, it depends on the hospital, it depends on the part of the country. You have to figure in, every little thing gets snipped out, every little thing goes to the lab, and then there's a lab test, a pathology test. There are complications because it's an invasive procedure. The CT has complications, but they're less often. But a CT has extra colonic findings, or they may have to roll you down for the follow-up colonoscopy. So and then it's like, well, how often do all these things happen? How often is there anesthesia? How often is there pathology? How often is there colonoscopy follow-up? And so we had to build after we analyzed the claims data, build a big model to put all this together and to do it over a patient's life, over a population lifetime, in order to get these trade-offs. And we got this published paper out of it. You can read about it yourself.
All right, we have one more. I'm gonna try and go real quick so that we can talk, right? So Medicare alternative payment models, right? So the population health problem here is that Medicare's out of money. Right, so according to
does everyone know what Medicare is?
So
because we have some international students.
Yeah, sure. So I think actually a lot of people, like current president included, were not clear on what Medicare was. So Medicare is the sort of government healthcare program in the United States for old people, right? So Medicaid is for financially needy people, and it's a state-based program that's paid for by the federal government. Medicare is a completely sort of centralized insurance program for elderly Americans that they pay into in their taxes. We all pay for
elderly and
disabled, and patients who have end-stage renal disease. There's sort of 3 categories that get you into Medicare. I think also Lou Gehrig's disease, but there's sort of specific categories of people, right? So over 65, disabled, or you have end-stage renal disease, which means you require kidney dialysis. Medicare spent $679 billion last year covering those populations. They cover about 55 million people. Something like 38 million of them through the traditional benefits, so parts A and B, which are hospital insurance, and then the voluntary physician insurance. And then the remaining elect what's called Medicare Advantage, where you sort of exit the traditional fee-for-service program, you join an HMO. So a private company manages that benefit for those people. So according to current projections by Medicare, their actuaries, the trust fund will be depleted by 2029. So this is related to the fact that the number of workers per beneficiary is going down. So problematic, right? Because it's not like they're actually saving the money I'm paying in taxes for me, right? They're using that money to pay for people now. So Medicare wants to save money, right? And so a lot of this is going through what they call alternative payment models. So the historical way to pay for care, right, through Medicare and other payers is fee for service. Someone does a service, we pay for it. And they're trying to find alternatives to that. So ways to pay for the value of services instead of just the quantity of services. And this is generally being referred to right now as alternative payment models. So there are several kinds you might have heard of. Accountable care organizations are sort of a broad one where one organization takes risk for the whole patient's care. Bundled payments where it's just for one interaction. So you're having a knee surgery or you have sort of cancer, right? And we're gonna create a bundle of services around that one thing. So that requires less infrastructure than an accountable care organization, which is a big sort of organizational issue. Patient-centered medical homes, so sort of saying the primary care physician is gonna manage your care, and we're gonna pay them an incentive for keeping you out of the hospital maybe. And then there's other types of pay for performance. So just saying we're gonna put some quality metrics. You know, people who meet these goals will get an extra payment. So this is something Medicare has been exploring a lot in the past, I would say 10 years, right? This is a graph from their website of all of the alternative payment model sites that they have going right now. It's basically everywhere, right? The orange ones represent states in which there is something exciting happening, like a state level model, and it's all the states. So I love that they made it into a chart. It's all the states. They just said all the states. And so this is an example of sort of, one of them is called, one of these programs we work with a lot, it's called the Comprehensive Care for Joint Replacement model. So joint replacement is one of the most sort of ubiquitous services that Medicare beneficiaries receive. They get their hips and knees replaced because apparently human hips and knees were not meant to last as long as we live now, or we're messing them up in some way, I'm sure. And so CMS started a mandatory model where they said across the country we're going to pick 67 regions. It accounts for about a quarter of the hospitals in the country in those regions, because the regions will be like the whole New York metropolitan area is a region. They say every hospital in that area, instead of just paying you for the hospitalization, which is what we do now, we're going to hold you financially accountable for the hospitalization, including the physician services, which are paid separately, and everything that happens for 90 days afterwards. So if the patient goes to a nursing home, if they go to an inpatient rehabilitation facility, you're going to be financially responsible for that. We're going to set a target, which is based on sort of your history mostly. It's a little bit based on what everyone else in this area is doing, right? And we're gonna sort of make sure that you are being held accountable. If you do a good job, we'll pay you extra, right? If you do a bad job, we're gonna make you pay us back. And it's mandatory. So like the hospitals are just like, oh, okay, that's great. I hate this idea. And Medicare has decided that they're gonna give claims data, because if you're a hospital, you can't know where your patients are going necessarily, right? You can't stop them from going to a rehabilitation facility if that's what they decide to do and that facility takes them. You sort of don't know what's happening necessarily, and 90 days is a very long time, right? So like on day 88 after hospitalization, the patient gets hit by a bus, like some of that is probably going to end up in this episode, right? And you might not know about it. If they don't come to your hospital, you have no idea. And so CMS decided to provide claims data to every hospital in this program. And so like this is an example we talk about in our relational databases. So the claims data comes in that set of files. There's about 20 files,
So each
right?
of these is a table, it's a big.
Each one is a big
database.
table, and they have different kinds of information, right? So there's beneficiary information. The first one, be dual, is like if they are dually eligible for Medicaid or not, right? That's all that's in it. And then there's some, the ones with sort of like IP detail, IP header, IP value. All of those three together represent the claims for an inpatient stay, and you have to merge them and understand how they work together. And so obviously, like, people don't know how to do this, so they hire us to do it for them. And so we have this sort of process where we take in those claims, right? We process them together into episodes, right? Because we have to put together all these different services for each patient. So we do that we were talking about this, before, we do that in SAS. We actually download it from a website using Python, right? So we use Python to batch download these files. And then we use SAS to process them. And then we export them and we put them into a business intelligence tool called ClickView. And so then the hospital can sort of log in, and they have this, this sort of interface where they can track their patients. Are they spending below the target? What's the money getting spent on, right? Are they at nursing homes? Are they at rehab facilities? Are they getting home health care? So these are the kinds of analyses we do with that claims data, and sort of the hospitals can use this to track how they're performing from a financial perspective. Okay, and this is an example of like, we get identifiable data, right? Because the data is going to the hospital. So it actually says like, John Smith got this service. So I'll click through some pictures, but I think that sort of concludes what we were hoping to cover today, and we'd love to take any questions that you have.
And feel free to get food while you ask.
Yeah, get the food. It's really good. I know.
Do they change the spaces on, like, for example, if it's a tier 1 versus tier 2 versus tier 3 hospital? Like, how much? Because the tier 1 hospitals tend to take the sicker patients. The more
So many
complicated.
of these programs have a risk adjustment component, which is actually risk adjustment is the topic of my dissertation. So I'd be delighted to speak at some future point on risk adjustment. And then that's to adjust for that there are hospitals that in fact do get the sicker patients or more poor patients. So Medicare long ago realized that among the Medicare beneficiaries, those who are poor enough to concurrently qualify for Medicaid, and those are called dual eligibles, which means they're quite poor, are sicker.
But it goes back to that question of what we're paying for, right? Because in a program where you're taking sort of risk for everything that happens to the patient, there would need to be sort of a risk adjustment to account for the fact that sicker patients cost more. But if you're saying sort of, one hospital is getting a sicker set of patients than another one, well, if you're not actually providing those sicker patients more services, then should you be getting paid more, right? And so I think there's two ways that question gets answered. One is in terms of what services are actually being provided, because you probably provide more complex services to sicker patients, so they pay at a higher rate, versus if you're taking risk for the patient in some way. And so you need to sort of have some kind of guarantee that you are going to get compensated for that in some way.
So one of the things we love data. I mean, hands-on write code, but they try not to let me, but actually.
We do.
But I mean, to truly make data talk, there's so much you need to know subject matter-wise too. And so, the big picture questions of what's happening, why is it happening, what are the policy goals, are the policy goals being met? And to be a really good healthcare data analyst, you got to read a lot of frequently very dry data dictionaries, regulations, policy documents to bring it all together to make that. Remember, data's fun, but it's the story you can build out of it that's even more fun, and that takes more than just data.
I have a question. I don't know if I can.
Of course.
If I understand completely about the example of colonoscopy. The Milliman were hired to do the cost of the two procedures.
Yeah.
And you give back some kind of orientation, just thinking about the cost of the procedures, or there is something like effectiveness of the two procedures.
And we had, in order to do the cost comparison, we had to build effectiveness in that. We didn't do the primary research on that. What we did is we pulled from the best research in the public literature and built that into our model.
It is in the model, though.
Okay. So that's the other thing that I spend a lot of time, because I have the research training. I spend a lot of time doing literature searches. So.
And you work with utility data too, like quality of life, or?
Sometimes we do. It depends on the project. I spent, it's now a public document, so I can speak of it. I'll speak about it. I spent about a year ago. No, it was 6 months. We were done in 6 months. Take that back. 6 months last year, doing a really exciting topic, burden of skin disease, which was adding up all the costs nationwide, Medicare, Medicaid, and commercial associated with skin disease. Yeah, that was fun. Bad joke, but it is Friday afternoon. I went around telling people, yeah, I'm really into skin these days. No pornography involved.
There was another question over here.
Yeah.
So I have a question about the diabetes example, and I'm sorry if I'm a little off, but so you said that because of the physicians not entering the data at the right time, or I mean like for the second and third year onwards when it was actually being carried, maybe if the human is making the error, the program can be coded in a way. I don't know, like, So that for like specific diseases, like chronic diseases like diabetes, then it just carries on its own.
So there's a huge cottage industry in that these days, and you don't want things to carry on their own because, in part, because you do want people to be interacting with their doctor about the care of diabetes, and you don't want just the system carrying it on. And sometimes people do, in fact, cease to have diabetes. It can happen. People post-bariatric surgery sometimes no longer have diabetes. But there's a cottage industry to cue doctors to say, according to the records of this patient, we think they have diabetes. Don't you want to put the diagnosis code here?
I think there's two parts to it, right? I think there's like the coding issue, and that's what I think Tia is speaking to, is this idea that like there are systems that actually encourage doctors to remember codes and put them on. They'll prompt you to say like, put a diabetes code on here. But on our side, like, we can also make those assumptions in our analysis. So if you're looking at claims data, you can say, like, people who had 4 or more diabetes claims in our index year, we're not going to recheck them every year. We're just going to assume, unless they have bariatric surgery, that they still have diabetes, right? And you can do that. It really depends on the research question.
One of the things I think it's important to note is that claims data isn't designed to do research. That's not why this data is collected. The data is collected so that they can get their money back, right? So we're using another source to do something we want to do, but they're not putting in these claims so that we can do research. They're putting in these claims so that they can get paid for the services that they're provided. So Pamela is right. It's motivated by how much money you're going to put in the codes that are going to get you the most money back for your service, because that's what you're doing it for. We're just fortunate that they do it and we can use the data. But it's not designed, am I making sense? It's not designed to do this, but we're using it for another purpose.
The way to summarize this is what's known in the data world as secondary data analysis. We are using data that's for another purpose, for our purpose. There are a lot of, most everyone with diabetes will have some drug costs. And so even the diagnosis codes that don't exist if you look for the drugs, if you see metformin, it's diabetes,
But even though the data aren't designed for this purpose, lots of policies are built from this data, right? So I don't want you to think that like researchers are just doing stuff with it. Like we tend to look at things and then that's how they make their policies. That's even sometimes how Medicare decides that they're not going to pay for certain things. It's usually when they go through their data, they figure out the policies that they're gonna follow.
Go ahead.
The example of diabetes is interesting because I almost finished my work in Brazil, and we are doing the cost of diabetes in Brazil. And because of this problem, that sometimes patients with diabetes seek medical care just with a complication. So because of the complication, the doctor doesn't remember to put the ID of the diabetes. So we now are doing the calculation of the attributable risk, considering all the patients that may be going to the hospital because of the diabetes.
Yeah. So, gangrene, if someone has gangrene, there's a good chance they're diabetic.
My question is, I think what you just talked about is more of the care provider oriented.
Yeah.
So, I'm wondering, have you do something for the patients, something patient oriented work?
Well, I mean, we're consultants,
Like,
so individual patients can't typically pay our bill. That said, what we do work for routinely are patient advocacy groups. So you have a patient advocacy group that says, look, we want a better understanding at a population level, how patients with end-stage renal disease are treated and what the incidence and prevalence of their complications are.
Or, for example, patient advocacy groups would have questions like, how does the deductible and coinsurance structure in the plan affect whether or not people are getting as much care, right? So if people who are in high deductible plans versus low deductible plans, if the patterns of care that we're seeing are different, that might suggest that putting in a high deductible is actually sort of discouraging people from getting care that they need. Like we do, I think there are interesting questions that patient advocacy groups also sort of seek answers from in claims data.
In fact, I'm speaking Monday, got on the plane Sunday night, to the American Cancer Society, and with respect to a further research project on colorectal cancer.
So I want to thank you all for spending your Friday afternoon with us. One of the things, we're going to send a follow-up, so please make sure you sign in. We're going to send a follow-up email. We picked Friday afternoon because we know there are no classes, but we may want to find a better time, although we would love to spend our Friday evenings with you guys. We can find a better time for us to meet as a lab, but right now we're going to do, it's only 2 more sessions, and right now we're going to leave them on Fridays just because it doesn't conflict with class levels, but we'll send out an email afterwards with just some quick sort of evaluation things about today. I thank you all for attending, and I really thank Tia and Pamela. Let's give them a big thanks.